to COVID. So myself, Dr. Shashwat Mishra, and in this particular lecture, we will be discussing about the gaseous anesthesia. Okay, so let's just start with. Okay, so what would we going to just discuss in this particular session is, we will be just firstly talking about the basics about the gaseous anesthesia, means the properties of an ideal gaseous anesthetics, like the terms like MAC. We will be just discussing them first. Okay, after which we will be discussing about the different type of gaseous anesthesia that are available in the market, right, for their effect, right? So starting with the properties of an ideal gaseous anesthesia. So what properties should a gaseous anesthesia should have? See, first of all, before discussing this, there is no particular gaseous anesthesia which is ideal. Then the question arises, then why we are studying this particular properties of an ideal gaseous anesthesia? So answer to that question is, see, we all know, we had studied the different kind of drug in the pharmacology, that no particular drug is ideal for its particular effect, because it would be having certain types of what side effect. But why we are studying this particular terms which are mentioned over here in the slide? Because see, we will be using that particular gaseous anesthesia which will be close to the properties that are mentioned over here. See, all gaseous anesthesia can't have all the 13 properties that are mentioned over here. But if consider there are two gaseous anesthesia, one is A, okay, one is A and one is B. Consider that if the gaseous anesthesia A will be fulfilling out of the 13, it would be fulfilling 5 properties of an ideal gaseous anesthesia. And if the gaseous anesthesia B will be fulfilling out of the 13 mentioned above, it would be fulfilling, let's say, 9. Okay. So which particular gaseous anesthesia will you prefer to give to the animal? Obviously the B one, because it is fulfilling the 9 properties of an ideal gaseous anesthesia above mentioned. Okay, and the gaseous anesthesia, which is A, it is fulfilling only the 5 ideal properties. So it is outweighing, the B gas is outweighing in purpose of its what? Its benefiting effect, right? So that's why we will be using that particular B gaseous anesthesia. So that's why we are over here studying the properties of an ideal gaseous anesthesia. And remember, there is no ideal gaseous anesthesia. Every anesthesia had certain types of side effects that we would be discussing in the latter part of this session also. Okay, so let's just discuss about the ideal properties. So it should be pleasant, it should be non-irritating, it should not cause any sort of nausea, it should have no after effect after its application, the induction and recovery should be fast for that particular gaseous anesthesia, it should provide an adequate amount of analgesia, immobility and the muscle relaxation. As we see in the general anesthetics also, that these particular 3 things should be there with any sort of anesthesia for performing any sort of surgery, right? It should be non-flammable and non-explosive, okay, because into the container which we are going to put the gaseous anesthesia, it should be non-flammable as well as non-explosive. Okay, it should be easy to administer to the particular patient you are having, and the margin of safety should be definitely wide. If we talk about, it should be non-reactive, non-toxic to the tissues, okay, and chemically compatible with the anesthetic device that we are having, like Mapelson devices. Okay, and 13th, which is the no fall in the blood pressure, that we will be seeing with in the case of like halothane also, that there is a fall on blood pressure also after its application, as it's what it do the sensitization of the myocardium towards the epinephrine and the norepinephrine. Okay, so let's just discuss about one term, which is the minimum alveolar concentration. So what this particular thing is, okay, so let's just see over here. So consider this is your alveoli, okay, and you're going to give what? A gaseous anesthesia. Okay, so in this particular thing, what we are going to see is, whenever you are going to give a gaseous anesthesia, what we look for is it should quickly diffuse out the alveoli and reach the target organ, which is I'm writing over TO. Okay, if it is quickly reaching the target organ after the diffusing through the alveoli, it is a major property we are considering. Now let's just see the definition of the MAC. So the definition goes how that it is what? The lowest concentration of any gaseous anesthesia in the pulmonary alveoli needed to produce a sort of immobility in response to any sort of painful stimulus in the 50% of the population. What does it mean? So whenever you're going to give, see, there are several gaseous anesthesia, halothane, isoflurane, tesflurane, sevoflurane. Now what we are seeing that if you're going to give a gaseous anesthesia, okay, then it would be reaching the alveoli, right? It would be diffusing out, right? Now we are considering over here that what is the minimum concentration for any of the particular what gaseous anesthesia to reach the alveoli and produce a sense of immobility towards the painful stimulus that generally produced during the surgery, okay, in the 50% of the population. That is what minimum alveolar concentration, right? Now, there is also one point that MEC is accepted as a valid measure for the potency of any sort of inhalation gaseous anesthetics, okay, because it remains fairly constant for most young and adult as well. Now, there is a correlation between the MEC and the potency, which is inversely, right? This inverse relation between the two is goes how? See, if the minimum alveolar concentration means more amount of gaseous anesthesia is required, so obviously the potency of that particular drug is less, right? Means at more concentration, it is showing less effect, right? The same effect, see, consider I'm taking a random values, okay? See, there is a gaseous anesthesia A, there is a gaseous anesthesia B. See, let's say that for an same effect, okay, means for the same effect towards a painful stimulus, the MAC value for the gaseous anesthesia, say it is 0.23, right? And the same, the B gaseous anesthesia, the MAC value is 188. So obviously, which gaseous anesthesia is more potent? That is the gaseous anesthesia A. Why? At lower concentration, the gaseous anesthesia is better performing, which is gaseous anesthesia A is better performing at the lower MSC value, means less amount of concentration is required to produce the same effect as similar to the B, which B is producing at the level of 188 MSC value. So I hope that you are understanding this particular correlation between the MEC and the potency, which is the inversely proportional. So if the more amount of the concentration is required, so the potency of the drug would be less and vice versa. Okay, so let us just discuss about more things that what a gaseous anesthesia should do. It should diffuse rapidly into the alveoli and the barrier tissues. Okay, now there are two parameters onto which the depth of the anesthesia depends on. So the very first parameter is the potency of the drug, which is the MAC value, obviously, and second one is the partial pressure of the drug. See, the more the partial pressure would be, obviously it would be showing more effect that would be seeing in the further move. Okay, and the induction and the recovery will depends on the rate of the change of the partial pressure in the brain. So the more quickly the partial pressure would be changing, so more quickly the induction and the recovery would be there, right? Now, how the transfer of the gaseous anesthesia is looks like. So first of all, it will be reaching the alveoli, okay, through the inhalation mode. Then it would be diffusing into the blood, and finally, it will be reaching into your brain. Correct. Now we are going to see that there are several factors that affects the partial pressure of gaseous anesthetics into the brain, right? So first one is the partial pressure of the gaseous anesthesia, right? So the more the partial pressure is, okay, so the more the partial pressure is, higher would be the gaseous anesthetic effect will be seen. Okay, so the higher inspired tension of the more gaseous anesthetic would be transferred into the blood and simultaneously to the brain. Okay, from the blood, it would be reaching to the brain and showing its more effect. So the more the partial pressure, so the more would be your induction towards the gaseous anesthesia. Now talking about the pulmonary ventilation, obviously, if you are going to inhale something, okay, if you are going to inhale something, if it is the ventilation means your lung is hyperventilating, means it is quickly inhaling and exhaling. So obviously it would be more and more effect towards the gaseous anesthesia. So the hyperventilation will bring more the gaseous anesthetic into your alveoli per minute. Okay. Now, then there is alveolar exchange. So the gaseous anesthesia diffuse freely across the membrane of the alveoli. Okay. Now, if there is any sort of disease like emphysema, pulmonary edema, or anything which is there, pneumonia, so there would be less perfusion of the gaseous anesthesia into the blood. Correct. Obviously, if there would be a barrier, so whether the gaseous anesthesia will be able to cross that particular barrier? No, obviously. So there would be less perfusion of the gaseous anesthesia into the blood. So it will lead to the slow induction as well as recovery, because during the recovery, the blood, the gaseous anesthesia will be transferring from the blood to the alveoli, right? So of course, when there is a condition like emphysema, so the gaseous anesthesia will not be able to cross that particular barrier in between the blood and the your alveolar membrane. Correct. Now there is a particular important part which is the solubility of the gaseous anesthesia. So before starting this particular part, I want to tell you that if this particular consider this is a blood vessel, okay, and this is my what a target organ into I want that blood gas should reach on time, right? Now consider that this particular what I'm marking over here orange is what your soluble gaseous anesthesia means. It is completely dissolved into the blood vessel, right? And then there is this green one which is still in the form of the gases. Okay, what I'm saying is this particular orange one is what? This particular your orange one is your soluble anesthetic, right, into the blood. And this particular green one is the gaseous form of the anesthesia. Means one is soluble into the blood and other is what you're in the form of the gas, right? So which would be more easily diffusible from the blood vessel into the target organ? Obviously, the gas, if it is soluble, it won't be diffusing quickly into the target organ, and the gas which is remain into the gaseous form into the blood vessel, it will quickly what transfer into the target organ, so the effect would be quicker in the gaseous state, right? I hope it is not a matter of issue and you understood it well, that if the gas is in the gaseous form, still in the gaseous form, into the blood vessel, okay, so it would be quickly diffusing out the blood vessel onto the target organ to show its effect, right? So that's what we are over discussing over here also. So it is the most important property determining the induction and the recovery. How? If the gas is highly soluble anesthetic, it will dissolve in the blood and there won't be any left gaseous form of the gaseous anesthesia into the blood, correct? So hence it won't be diffusing into the brain or the target organ I'm mentioning over there. Okay, so to diffuse into the brain, the gaseous anesthesia should be much soluble, shouldn't be much soluble, and if it would be more soluble, then we have to firstly saturate the blood with the gaseous anesthesia. Obviously, पहले हमें क्या करना पड़ेगा कि हमें सैचुरेट करना पड़ेगा ब्लड को, ठीक है? अगर वो ज़्यादा सॉल्युबल है, कोई भी गैसियस एनेस्थीसिया ज़्यादा सॉल्युबल है, तो हमें पहले क्या करना पड़ेगा? हमें पहले ब्लड को सैचुरेट करना पड़ेगा एक सर्टेन लेवल तक। फिर उसके बाद जब हम और उस पर्टिकुलर गैसियस एनेस्थीसिया को देंगे, तब जाके वो एक गैसियस फॉर्म में आएगा। ओके, सो मोर अमाउंट ऑफ द गैसियस एनेस्थीसिया वुड बी रिक्वायर्ड। फॉर एन एग्जांपल, योर N2O, राइट? After which it can only be in the free gaseous form. That's what I was saying. Okay, so the large amount of the gaseous anesthesia that is highly soluble into the blood, for an example ether, must be dissolved before its partial pressure is raised into the blood. So the rise and the fall of the partial pressure in the brain and the consequently induction as well as the recovery is slow. Okay, now there are drugs with the low solubility, means the drugs that remain in the gaseous state. For an example, your N2O, sevoflurane, desflurane, and the desflurane is the fastest acting. Okay, and the methoxyflurane, that is, there is a drug which is poorly acting, slow acting, and having a good solubility. That is what we do not want. We do not want a drug to be more good soluble. Then there is a term which is the blood gas partition, which is the equals to the concentration of the anesthesia in the blood and the concentration of the anesthesia in the gaseous form. Okay, now, the desflurane and the sevoflurane are the most commonly inhalation anesthesia that are used due to their low blood gas solubility. That's what I want. Okay, so for an gaseous anesthesia for rapid induction and recovery, we want it to be present in the gaseous state in the blood vessel, not in a soluble state. So the more the solubility, less would be the rapid induction and the recovery. So that's why what mentioned over here, that the solubility of the drug is inversely proportional to the effect of the drug. Okay, now solubility into the tissues. Okay, so the halothane, for an example, is more lipid soluble and enters the adipose tissue easily and leaves slowly, which will be showing the prolonged effect of the halothane. Okay, so the concentration of the anesthesia is more in the white matter than the gray matter of the brain. Remember this part. Okay, now there is a particular part which is the cerebral perfusion also. Okay, so brain is an highly perfused organ, we all know. So the gaseous anesthesia will be quickly delivered, obviously. And how it would be hastened means इसको हम increase कैसे कर सकते हैं? Obviously हमने discuss किया था क्या, hyperventilation. So hyperventilation का case कब दिखता है? जब हमारे पास या तो excessive CO2 की concentration आसपास हो या फिर हमारे पास O2 की deficiency हो, यही दो condition है, ठीक है? तो अगर हमने क्या किया कि हम एक जो see, obviously the gaseous anesthesia are not given alone. It is given in a certain mixture. Okay, mixture of gases. Okay, so if you want to just increase the action of that particular gaseous anesthesia, so what we do is that we in that particular mixture of the gaseous anesthesia we give what CO2 along with the inhalation and anesthetic. Why? Because CO2 will induce what, hyperventilation, and that's what we want. We want that a gaseous anesthesia should rapidly inhale and exhale, right, so that its effect could be visible, right? Which cause the vasodilation and induction and recovery would be faster, correct? Now, I will just talk about the elimination of the particular gaseous anesthesia. So, all inhaled anesthesia are mainly eliminated through the lungs, except one, which is the halothane. Okay, so halothane is a gaseous anesthesia which is going to metabolize near about more than 20% into the liver. Remember, it is an important point. That's why the halothane is hepatotoxic, which may lead to hepatitis. It is an objective point also for the ICR examination, PG examination also. Okay, so the metabolism of majority of the inhalant anesthetic is there in the what? Your lung, while in the case of the halothane, the metabolism of the halothane is there in the liver, right? It is a special point. Now, the halothane was previously used in the pediatric patients, means in the children, because it has a nature of non-irritant, sweet smelling nature, allowing the smooth induction and recovery also. Okay, without causing any sort of bronchial spasm or any excessive airway secretion. So, because see what happens, there is an issue with the gaseous anesthesia, which is that there are certain times that the gaseous anesthesia lead to what? Your secretion through the respiratory tract. That's why we give atropine before the what? Your application of the inhalant anesthetics. Okay, so the mixture that was I was telling you that N2O is generally used as within carrier adjuvant. Okay, we are going to use N2O as a carrier and an adjuvant to the ether anesthetics. So the mixture of the gases that are used is 70% near about N2O, 25 to 30% of the O2, and 0.2 to 2% of the potent gaseous anesthetic. So that's how we are going to apply this particular gaseous anesthesia. Okay, now talking about that, N2O is having a good analgesic property. Even 20% of that will produce analgesia equivalent to the by the conventional doses of the morphine. Okay, so it is a good analgesic. Okay, so now there are also point that the ether is producing what? Irritating vapor also. Now that's what's the point I was discussing, that atropine must be given as a premedication to prevent what? The patient from drowning in its own secretion, because the inhalant anesthetics lead to what? Production of the secretion throughout the respiratory tract. Now, if we'll talk about the cyclopropane and the isoflurane, these are less toxic than as compared to the halothane or the methoxyflurane. Now, this is the classification of the inhalant anesthetics, which is the volatile liquid and the gaseous anesthesia. So, ether, halothane, methoxyflurane, enflurane, isoflurane, desflurane, these all are volatile liquids, and out of which the methoxyflurane is the most potent due to its lowest MAC value. It is an objective point, remember. Now, the gaseous anesthetics, which are in the gaseous form, okay, it is the nitrous oxide, cyclopropane, ethylene, and the CO2. If we talk about the cyclopropane and the ethylene, they are flammable and highly explosive. So just keep into the consideration. So it is the cylinder color, which sometimes may be asked in the examination. So oxygen is having the green color, the CO2 is having the gray color, the N2 cylinder is having the light blue color, the cyclopropane is having orange color, the helium is having the brown color, ethylene is having red color, and the mixture of the CO2 and the O2 gases into a single cylinder is having a color code of gray to green. Now here is the MAC value of the different type of what? Gaseous anesthesia. So for the halothane, the MAC value is 0.86 in the cases of the dog and 0.98 in the cases of the cat, right? If we talk about the most potent your what? Gaseous anesthesia, it is the methoxyflurane. See, look at the concentration that is required, just 0.23 in both dog and cat. If we talk about the least potent, that is nitrous oxide, having a MAC value of 188 in the dogs and 255 in the cats. Just remember this particular data is important. Just learn halothane, isoflurane, methoxyflurane, and nitrous oxide. And talking about the individual what? Individual drugs. So if we talk about the ether, it is colorless, highly volatile, having a pungent smell, and highly inflammable agent. Okay, ether. What's the property of the ether is that it irritates the issue, leading to irritate the tissues, leading to what? Excessive secretion through the respiratory tract. Okay, so the flow of saliva and the mucus increases, which interferes with the respiration that I had told you. Okay, it increases the susceptibility towards the post-operative pneumonia due to the excessive secretion that is there. Ether also irritates the kidney tissue and reduce the urine output. Albuminuria and tubular cast are common with that. Now talking about the methoxyflurane, it is a non-flammable agent. It is having a fruity odor. And we'll talk about the disadvantage. It can cross the placental barrier that we do not want into the pregnant patient. That's why we cannot just applicable that particular methoxyflurane into the pregnant. Okay. Now it has slower induction and the recovery period, depression in the blood pressure, that's we do not want, and the respiratory acidosis is sometimes seen. Okay, there is also one point with the methoxyflurane is that it produces the renal toxic fluoride ions. So it should not be used with the renally excreted drugs like tetracycline and the flunixin meglumine. Okay, talking about the halothane, which is an important part we have to discuss. So it is a non-explosive, non-flammable, obviously, but it can decompose in the presence of light. That's why it is pour into an amber glass bottles. Okay, now the halothane is twice as potent as the chloroform and 4 times potent as the diethyl ether. Now there is a particular part that we have to see that it shows what a dose dependent depression and the cardiopulmonary system. So the more the dosage of the halothane, it would be showing more the cardiopulmonary depression. Why it would be showing the cardiopulmonary depression? Because it leads the myocardium muscles more sensitization towards the what epinephrine and the norepinephrine means the catecholamines, right? So the halothane sensitizes the muscles of the myocardium towards the epinephrine and norepinephrine. That's why the dose dependent depression it's seen, and which will lead to the lower the blood pressure and the direct myocardial depression. Okay, as well as there would be vasodilation depression of the vasomotor tonicity center and the medulla. It would be producing hypertension that we have seen. And halothane is a safe anesthesia in the cases of the severe anemia in the particular what any anemic patient could be any patient with the anemia can be what you can use halothane in the anemic patient also. Okay, salivary mucus and the bronchial secretion are absent during the halothane anesthesia, unlike the methoxychloroquine. And the concurrent use of the succinylcholine is contraindicated in the cases of the horse, and the MAC value is 0.86. Okay, now, more important, which is the objective part, is that the side effects of the halothane. So, halothane is showing malignant hypothermia as well as it is hepatotoxic that we had discussed above. Now, talking about the isoflurane, it is non-flammable, non-explosive, stable compound and does not break down in the contact of the soda lime or in the presence of the lights. It is less potent than halothane and the methoxychloroquine. Okay, and relatively insoluble, leading to the fast induction and recovery that what we want. But there is certain disadvantage also that it initiate fetal hypothermia in the cases of the swine. So you can just see this particular what disadvantage, and more respiratory depressant as in case of the halothane. So it is more respiratory depressant also. So there is fewer tendency to sensitize the heart to the catecholamine than the halothane, and profound respiratory depressant effects is seen in the cases of the what dogs and cats. I'm talking about the desflurane. So it is what totally fluorinated ether. It is least soluble and having a volatile inhalation anesthetic agent, and the MEC value in the dogs is 7.2. Talking about the chloroform, so because it is the cardiovascular, hepatic, and the renal toxic, it is no longer used. So 1% alcohol is added to the chloroform to prevent the production of the phosgene gas. Remember this particular. So talking about the trichloroethylene, it is a sweet smelling anesthetic. So now the disadvantage is cardiotoxicity, poor muscle relaxation, and the sensitization of the myocardium towards the epinephrine. Now talking about the nitrous oxide, which is quite important. So it is non-flammable, non-explosive, non-irritant. Remember, now it is stored under the pressure of the 750 psi in the blue cylinder. We had discussed that particular thing. It is poured in the blue cylinder. It is administered in the semi-closed or the closed system with the oxygen. Okay, and it cannot be given as a sole anesthetics. Okay, remember that too. Okay, analgesia produced is mediated through the opioid receptors, right? Just remember this, that the analgesia that is produced by the nitrous oxide is due to the opiate receptor that are there. Okay, and the minimal cardiopulmonary side effect is seen, but the side effect which is there is the malignant hyperthermia. Okay, now, no muscle relaxation property is there with the N2, okay, and it is teratogenic and exhale unaltered from the lung. And N2 must be given at least 80% of the concentration to produce the anesthesia. It is having a much higher MAC value that you should remember that in dogs it is 188 and in cats it 255. Okay, just remember it is important. The halothane, isoflurane, your methoxyflurane, and the N2. Remember the MAC value of these. Okay, so the common cause of the death due to N2 is the failure to add sufficient oxygen in the anesthetic mixture. Now there are two particular side effects of the means the effect that is shown by the N2, which is the second gas effect, which goes how that the relative insoluble gas is present in the high concentration with a mixture of the greatly solubility, right? So the N2, which is least soluble, okay, and the halothane, which is more N2, which is more soluble, and halothane, which is less soluble. So the relatively insoluble gas, which is the N2, because the partial pressure of the Gas is greater. It crosses the bloodstream quickly, thus decrease the volume of the alveoli and therefore concentrate the remaining gas. Right? Means the effect of the halothane is seen due to the what? Your N2, right? Now there is also a diffusion hypoxia that is seen, which is due to the N2, which is possibly with the low solubility agent, which are administered in the high concentration like N2. Okay, diffusion of nitrous oxide into the alveoli during the recovery from the prolonged N2 administration may induce hypoxia. Just remember these two terms, that the second gas effect and the diffusion hypoxia is seen in the cases of the N2. So this was all about the session, and if you want the handouts or the notes, it would be there in the description. So thank you everyone for watching.